The breasts are the most prominent superficial structures in the anterior thoracic wall, consisting of glandular tissue and a supporting fibrous and fatty matrix. This glandular tissue, or mammary glands, are found in the subcutaneous tissue overlying the pectoralis major and minor muscles. The amount of fat surrounding this glandular tissue will determine the size of the breasts. Breasts have a circular body and a nipple in the center, surrounded by a pigmented area of skin called the areola. Each breast has the following boundaries: transversally from the lateral border of the sternum to the mid-axillary line, and vertically from the 2nd through the 6th ribs. 2/3 of the underlying tissue of the breast is formed by the pectoral fascia covering the pectoralis major, and the other third is formed by the fascia that covers the serratus anterior muscle. A small part of the breast might extend along the inferiolateral edge of the pectoralis major, going towards the axillary fossa or the armpit. Here it forms the axillary process or tail, called the tail of Spence. Now let's take a look at the sagittal section of the female breast. As you can see, there's a fine space between the breast and the pectoral fascia. This is called the retromammary space, or bursa, which is a loose subcutaneous tissue plane. This plane contains a small amount of fat, which allows the breast to move a bit on the pectoral fascia. Breasts contain the mammary glands responsible for lactation in females. Mammary glands are made up of 12 to 20 lobes, each of them containing many smaller lobules. These smaller lobules have grape-like clusters of alveoli that contain mammary secretory epithelial cells, the milk-producing cells of lactation. These alveoli, lobules, and lobes are connected through a network of ducts called the lactiferous ducts, and eventually form unique lactiferous ducts for each lobe, which opens independently to the areola to drain the milk produced during lactation. Each lactiferous duct has a dilated portion deep to the areola, called the lactiferous sinus, in which there's a small drop of milk that accumulates or remains in a nursing mother, which becomes expelled from the areola when compressed during feeding. Next, the stroma of the breast is composed of adipose tissue and fibrous connective tissue. In a non-lactating state, the adipose tissue is situated between the lobes and makes up most of the breast volume. The fibrous connective tissue of the stroma goes on to form fibrous condensations called the suspensory ligaments of Cooper, which firmly attach the mammary glands to the dermis of the overlaying skin. These fibrous connective tissue attachments help support the lobes and lobules of the mammary glands. Moving on, the areolae surround the nipples, which are typically located around the 4th intercostal space, lateral to the midclavicular line, but this varies depending on the size of the breast. Each areola contains a large number of sebaceous glands, which get bigger during pregnancy and secrete an oily substance that acts as a lubricant for the areola and nipple. The nipples are conical or cylindrical prominences in the center of the areola. Keep in mind that the nipples have no fat, hair, or sweat glands. The lactiferous ducts open into the tips of the nipples. Structurally, the nipples are composed of circularly arranged smooth muscle fibers that compress the lactiferous ducts to help express milk during lactation. Now, let's look at the arterial supply of the breast, which derives from several arteries: the medial mammary branches, the lateral thoracic artery, the thoracoacromial arteries, and posterior intercostal arteries. The medial mammary branches come from the internal thoracic artery, which originates from the subclavian artery. The lateral thoracic and thoracoacromial arteries are branches of the axillary artery. The posterior intercostal arteries are branches of the thoracic aorta in the 2nd, 3rd, and 4th intercostal spaces. And finally, the veins of the breast mainly drain into the axillary vein, but some also drain into the internal thoracic vein. Let's move on to the lymphatic drainage of the breast. Basically, lymph passes from the nipple, areola, and glandular lobules to the subareolar lymphatic plexus. From here, most lymph, especially from the lateral breast quadrants, initially drains into the anterior or pectoral nodes, and then to the axillary lymph nodes. Some lymph may drain directly to other axillary nodes, or even to interpectoral, deltopectoral, supraclavicular, or inferior deep cervical nodes. The remaining lymph, especially from the medial breast quadrants, drains to the peristernal lymph nodes or to the opposite breast. Lymph from the inferior quadrants may pass deeply to abdominal lymph nodes, specifically to the subdiaphragmatic inferior phrenic lymph nodes. Lymph from the skin of the breast, with the exception of the nipple and areola, drains into the ipsilateral axillary, inferior deep cervical, and infraclavicular lymph nodes, and also into the peristernal lymph nodes of both sides. Lymph from the axillary nodes first drains into the clavicular lymph nodes, and then into the subclavian lymphatic trunk. And finally, lymph from the peristernal nodes enters the bronchomediastinal lymphatic trunks, which goes on to eventually drain into the venous circulation. Finally, the nerves of the breast come from anterior and lateral cutaneous branches of the 4th through 6th intercostal nerves. The branches of the intercostal nerves go through the pectoral fascia covering the pectoralis major in order to reach the overlying subcutaneous tissue and skin of the breast. The branches of the intercostal nerves carry sensory fibers from the skin of the breast and sympathetic fibers to the blood vessels in the breasts and smooth muscle in the skin and nipple. Alright, as a quick recap, the breasts extend transversely from the lateral border of the sternum to the mid-axillary line, and vertically from the 2nd through the 6th ribs. A small part of the breast might extend along the inferolateral edge of the pectoralis major, forming the tail of Spence. The retromammary space is between the breast and the pectoral fascia, and allows movement of the breast to the structures deep to it. The mammary glands are made up of 12 to 20 lobes, each of them containing several small lobules, which further contain clusters of alveoli that have mammary secretory epithelial cells. The alveoli, lobules, and lobes are connected to ducts that join to form larger ducts called lactiferous ducts, which drain the mammary glands through lactiferous sinuses to the tip of the nipple. The nipples are conical or cylindrical prominences in the center of the areola and have no fat, hair, or sweat glands. The areola are pigmented areas of skin surrounding the nipple. The stroma of the breast is composed of adipose tissue and fibrous connective tissue, which make up the bulk of the breast tissue and support the mammary glands respectively. Arteries of the breast include the medial mammary branches, the lateral thoracic artery, the thoracoacromial arteries, and posterior intercostal arteries. The venous drainage is mainly to the axillary vein, but there is some drainage to the internal thoracic vein. Lymph from the lateral breast quadrants drains to the axillary lymph nodes, and initially to the anterior and pectoral nodes. The remaining lymph, especially from medial breast quadrants, drains to the peristernal lymph nodes or to the opposite breast. Lymph from the inferior quadrants may pass deeply to the abdominal lymph nodes. Lymph from the skin of the breast, with the exception of the nipple and areola, drains into the ipsilateral axillary, inferior deep cervical, and infraclavicular lymph nodes, and also into the peristernal lymph nodes of both sides. The nerves innervating the breast come from anterior and lateral cutaneous branches of the 4th through 6th intercostal nerves.
The female reproductive system is made up of external and internal organs. The external organs lie in an area called the vulva, and they include the labia, the clitoris, and the vaginal opening. The internal reproductive organs can be found within the pelvic cavity, and they include the ovaries, which produce the female sex cells called oocytes, as well as sex hormones estrogen and progesterone, the uterine tubes, which carry the fertilized oocyte to the uterine cavity, the uterus, which houses the growing fetus during pregnancy, and the vagina, which is involved both in intercourse and fetal delivery. Now, the ovaries, uterine tubes, and uterus lie within the pelvis and are covered by a double sheet of peritoneum called the broad ligament. This extends from the sides of the uterus to the lateral wall and floor of the pelvis. To visualize the broad ligament, imagine yourself standing with your arms outstretched, holding a ball in each hand. Your body is the uterus, your arms are the uterine tubes, and the balls are the ovaries. Now, a sheet is draped over you, and this sheet represents the peritoneum. You can see now how the broad ligament of the uterus is a double fold. Now, the broad ligament has three mesenteries: the mesovarium, which is associated with the ovaries, the mesosalpinx, which covers the uterine tubes, and mesometrium, which covers the uterus. Let's now look at each of the organs of the female reproductive system, starting with the ovaries. The ovaries are the site of egg production, or oogenesis, and also release progesterone and estrogen during the different phases of the menstrual cycle. The ovaries usually sit near the lateral pelvic wall where the broad ligament attaches and are suspended by a subdivision of the broad ligament called the mesovarium and the suspensory ligament of the ovary, which is a continuation of the mesovarium. The ovarian vessels, nerves, and lymphatics pass through this ligament to enter or exit the superolateral surface of the ovary. Now, the mesovarium does not necessarily cover the ovary. It attaches the anterior portion of the ovary to the broad ligament and is continuous with the outermost layer of the ovary. Medially, between the two layers of the mesovarium, there's a fibrous band called the ligament of the ovary, which travels to the uterus, then continues as the round ligament of the uterus. The ligament of the ovary and the round ligament of the uterus are embryological remnants of a structure known as the gubernaculum. The two gubernacula are embryonic structures that guide the ovaries in their descent from the abdomen to the pelvis. Now, each menstrual cycle, one of the ovaries releases an ovum, sometimes called an egg, into the peritoneal cavity in a process called ovulation. The ovum can't stay there forever or it won't be able to be fertilized, and so it travels through the uterine tubes. The uterine tubes extend laterally from both sides of the horns of the uterus to the peritoneal cavity near the ovaries. These tubes lie inside the upper and anterior parts of the broad ligament called the mesosalpinx. The uterine tubes have two main purposes. They carry the ovum from the peritoneal cavity near the ovaries to the uterine cavity. Second, they form a space for the fusion of egg and sperm, a process called fertilization. Alright, now each uterine tube is divided into 4 parts. Let's start with the most lateral part called the infundibulum. The funnel-shaped infundibulum opens into the peritoneal cavity through an opening called the abdominal ostium. Around this ostium, there are finger-like projections called fimbriae, which cover the surface of the ovaries. These fimbriae receive the ovum after ovulation, and they guide it inside the uterine tubes. The next part is the ampulla, which is where fertilization usually occurs. Next is the isthmus, which is the narrowest part of the tube that ends by joining to the lateral walls of the uterus. Finally, the uterine or intramural part passes through the uterine wall and opens into the uterine cavity through an opening called the uterine ostium. There are 2 main arteries that supply both the ovaries and the uterine tubes. First is the ovarian arteries, which arise from the abdominal aorta and travel inferiorly behind the peritoneum and enter the suspensory ligaments of the ovaries to supply the lateral sides of the ovaries and the uterine tubes. Next are the ascending branches of the uterine arteries, which arise from the internal iliac arteries. These branches ascend on the lateral sides of the uterus, reaching the medial sides of the ovaries and the uterine tubes. Now, both ovarian and ascending uterine arteries terminate by bifurcating into ovarian and tubal branches, and these branches supply the ovaries and the uterine tubes respectively. These branches also anastomose to form a collateral circulation between abdominal and pelvic arteries. Now, veins draining the ovaries meet at the lateral end of the broad ligament to form a network of veins called the pampiniform plexus. This plexus gives rise to the right and left ovarian veins. The right ovarian vein ascends to drain into the inferior vena cava, and the left ovarian vein ascends to drain into the left renal vein. Finally, venous blood from the uterine tubes drains into the ovarian veins and uterine venous plexuses, which lie along the lateral sides of the uterus. Alright, now let's discuss the nerves that supply the ovaries and the uterine tubes. These nerves arise from two plexuses, the ovarian plexus, which descends along the ovarian blood vessels, and the uterovaginal plexus, which accompanies the uterine arteries at the sides of the uterus. Now, the ovaries and the uterine tubes lie above the pelvic pain line, which means their visceral afferent pain fibers travel with the sympathetic fibers of the ovarian plexus and the lumbar splanchnic nerves. Okay, now let's take a deep breath and have a quick quiz. Can you name these parts of the broad ligament? Alright, now let's look at the uterus, which is a hollow, pear-shaped organ that carries the developing fetus throughout pregnancy. The uterus has two main parts called the body and the cervix. Let's start with the body, which forms the upper 2/3 of the organ. It is freely movable and lies between the layers of the broad ligament. The superior, rounded part of the body that lies above the uterine openings of the uterine tubes is called the fundus of the uterus. The inferior part of the body forms a constricted segment called the isthmus of the uterus, which is where the body of the uterus is continuous with the cervix. The cervix is a narrow cylinder that forms the lower third of the uterus and has two openings. The first is called the external os that opens into the vagina, and the second is the internal os, which opens into the uterine cavity. Alright, now let's look at the internal features of the uterus. First is the uterine cavity, which extends superolaterally, forming the regions where the uterine tubes join, called the uterine horns. Next is the cervical canal, located within the cervix. This canal extends from the anatomical internal os, which opens into the uterine cavity, to the external os, where it communicates with the lumen of the vagina. During delivery, the fetus descends through the cervical canal and the vagina, together called the birth canal. Alright, now that we know about the external and internal features of the uterus, let's talk about its location and orientation in the pelvis. The uterus lies in the lesser pelvis, with the body resting on the upper surface of the urinary bladder and the cervix lying between the bladder and the rectum. The uterus itself is covered by the mesometrium of the broad ligament, which is a double layer of peritoneum. This peritoneum continues over the anterior and posterior surfaces of the uterus, except for the cervix. Anteriorly, the peritoneum reflects from the uterus onto the superior surface of the bladder, forming the vesico-uterine pouch. Posteriorly, the peritoneum reflects from the body of the uterus and the supravaginal part of the cervix onto the anterior surface of the rectum, forming the recto-uterine pouch or pouch of Douglas. Now, the position of the uterus can get a bit confusing, so let's break it down. Most commonly, the uterus is in an anteverted and anteflexed position. Now, what does that mean? Well, these are just angles on different parts of the uterus and cervix. The angle of version is formed by an imaginary longitudinal line through the cervix and one through the vagina. An anteverted uterus is tilted anteriorly with an almost 90-degree angle. The angle of flexion is formed by an imaginary longitudinal line through the body of the uterus and one through the cervix. An anteflexed uterus has an angle measuring about 170 degrees. Although the uterus is usually in an anteflexed and anteverted position, some individuals can have a retroverted, retroflexed uterus. Retroverted means that the uterus tilts posteriorly over the vagina, which increases the angle of version. Retroflexed means that the fundus of the uterus tilts posterior over the cervix, which increases the angle of flexion. Now, the uterus is anchored within the pelvis by various mechanisms, including uterine ligaments, which attach to the superior and lateral surfaces of the uterus. The ligaments that attach to the superior surface include the mesometrium and the round ligaments. The mesometrium is the largest part of the broad ligament that lies below the mesovarium and mesosalpinx. Next is the round ligament of the uterus, which starts antero-inferior to the junction between the uterus and the uterine tubes. Then, they run through the inguinal canal, reaching the labia majora. Remember, the round ligament of the uterus and the ligament of the ovary are the remnants of the ovarian gubernaculum. Now, the ligaments that attach to the lateral surface of the uterus include the cardinal and uterosacral ligaments. The cardinal ligament, also called the transverse cervical ligament, extends from the lateral surfaces of the cervix and the vagina to the lateral pelvic walls. The uterosacral ligaments extend superiorly and posteriorly from the sides of the cervix to the middle of the sacrum. The lower surface of the uterus is supported by structures of the pelvic floor, including the levator ani, perineal membrane, and perineal body. The uterus is also supported by its position over the bladder, especially in an anteverted, anteflexed orientation. And just a quick note, the arterial blood supply of the uterus comes mainly from the uterine arteries, which arise from the internal iliac arteries. Deoxygenated blood from the uterus drains into the uterine venous plexus, which lies between the two layers of the broad ligament. The plexus drains into the uterine veins, which exit the broad ligament on each side and drain into the internal iliac veins. Okay, now let's take a deep breath and have a quick quiz. Can you name the internal features of the uterus on this image? Finally, let's discuss the vagina, which is a musculomembranous tube that provides a passage for the menstrual fluid, forms the lower part of the birth canal, and receives the penis and the ejaculate during sexual intercourse. The vagina extends from the cervix to the external opening called the vaginal orifice. This orifice, along with the external urethral orifice and the openings of the great vestibular glands, open into the cleft between the labia minora called the vestibule of the vagina. Now, the upper part of the vagina forms a recess around the cervix called the vaginal fornix. The fornix has 4 parts, 2 lateral parts and an anterior and posterior part. The posterior vaginal fornix is the deepest part and lies directly anterior to the recto-uterine pouch. The vagina lies posterior to the urinary bladder and urethra and anterior to the rectum. Arterial blood supply for the upper part of the vagina is provided by the uterine arteries, while that for the middle and lower parts comes from the vaginal and internal pudendal arteries. Venous blood from the vagina enters a plexus of veins along the sides of the vagina called the vaginal venous plexus, which is drained by the vaginal veins. The vaginal venous plexus combines with the uterine venous plexus to form the uterovaginal venous plexus, which is mainly drained by the uterine veins into the internal iliac veins. The uterovaginal plexus also communicates with the vesical and rectal venous plexuses. Finally, let's discuss the innervation of the vagina and the uterus. The innervation of the vagina divides roughly into an upper 3/4 and a lower quarter. The lower quarter of the vagina is the only portion that receives somatic innervation by a branch of the pudendal nerve, called the deep perineal nerve, making this area sensitive to touch and temperature. The innervation of the upper 3/4 of the vagina, on the other hand, overlaps with the innervation of the uterus. The innervation of these structures is visceral, and the nerve fibers come from the uterovaginal nerve plexus. These fibers include sympathetic, parasympathetic, and visceral afferent fibers. Lastly, the innervation of the uterus is divided by the pelvic pain line, which is an imaginary line in the pelvis. Structures that lie above the pelvic pain line, like the fundus and the body of the uterus, send pain impulses along visceral afferent fibers that follow the sympathetic nerve fibers. Structures that lie below the pelvic pain line, like the cervix and the vagina, send pain impulses along visceral afferent fibers that follow the parasympathetic nerve fibers. Alright, as a quick recap, the ovaries, uterine tubes, and the uterus are covered by a double sheet of peritoneum called the broad ligament. The broad ligament has 3 parts: the mesovarium that is associated with the ovaries, the mesosalpinx that covers uterine tubes, and the mesometrium that covers the uterus. The ovaries are the site of egg production and hormone release and are supported by the suspensory ligament that carries the vessels that supply them and the ligament of the ovary. The uterine tubes have 4 parts: the infundibulum with its fimbriae, the ampulla, the isthmus, and the intramural part. The ovarian artery and the ascending branch of the uterine artery supply the ovaries and the uterine tubes. The pampiniform plexus drains the ovaries and uterine tubes and merges to form a right and left ovarian vein that drains into the inferior vena cava and left renal vein, respectively. The uterus lies in the lesser pelvis, with the body resting on the upper surface of the urinary bladder and the cervix lying between the bladder and the rectum. The ligaments that support the uterus include the broad, round, cardinal, and uterosacral ligaments. The blood supply of the uterus is provided by the uterine arteries, and the veins drain into the internal iliac veins. Lastly, the vagina is a musculomembranous tube that extends from the cervical canal to the vaginal orifice. There are 3 arteries supplying the vagina: the uterine arteries, which supply the upper part, and the vaginal and internal pudendal arteries, which supply the middle and lower parts. With the exception of the lower 1/4 of the vagina, which is under somatic innervation, the pelvic organs of the female reproductive system are under visceral innervation. The ovaries, uterine tubes, fundus, and body of the uterus lie above the pelvic pain line, and their visceral afferent fibers follow the sympathetic fibers. The cervix and upper 3/4 of the vagina lie below the pelvic pain line, and their afferent fibers follow the parasympathetic fibers.
The pelvic cavity is a funnel-shaped space surrounded by pelvic bones, and it contains organs, such as the urinary bladder, rectum, and pelvic genitals, to name a few. The pelvic cavity and the abdominal cavity together form the larger abdominopelvic cavity. The pelvic cavity is bounded superiorly by the pelvic inlet, which connects to the abdominal cavity, and inferiorly it's bounded by a group of muscles and the fascia surrounding them, called the pelvic floor or pelvic diaphragm, which is suspended above the pelvic outlet, with its central portion dipping below it. The pelvic cavity also has an antero-inferior wall, 2 lateral walls, and a posterior wall. So let's start with the antero-inferior wall, formed by the bodies and rami of pubic bones, and the pubic symphysis. Each pubic bone has 3 parts: a body, and a superior and inferior ramus. The body of the pubic bone is the thickest, most anterior part of the pubic bone. Anteriorly, the bodies of the right and left pubic bones are joined together in the median plane to form the pubic symphysis. Now, in an anatomical position, the pelvis is tilted in the anterior-posterior plane, making the pubic bones and pubic symphysis act more like a weight-bearing floor than an anterior wall. The lateral walls of the pelvic cavity are formed by the right and left hip bones. Each hip bone has an inferior opening called the obturator foramen, which is formed by the pubis and the ischium. The foramen is partially covered by a membrane called the obturator membrane. This membrane and the pelvic surfaces of the ilium and ischium give origin to a muscle called the obturator internus, which pads most of the lateral pelvic wall. Now, the fibers of the obturator internus muscle converge posteriorly to become tendinous, and then travel through a foramen called the lesser sciatic foramen. Finally, they attach to a large area on the lateral side of the femur called the greater trochanter. The medial surfaces of the obturator internus are covered by a fascia called the obturator fascia. This fascia covers most of the muscle and becomes thicker medially to form a tendinous arch. This arch gives origin to one of the muscles forming the pelvic floor or pelvic diaphragm. Additionally, the attachment of the pelvic diaphragm to the obturator fascia divides the obturator internus into a superior pelvic portion and an inferior perineal portion. Now let's move on to the posterior wall. The posterior wall has a bony and a musculoligamentous part. The bony part is formed by the sacrum and coccyx, which are the final parts of the vertebral column. The sacrum is a wedge-shaped bone composed of 5 fused sacral vertebrae. It forms the posterior-superior wall of the pelvic cavity and has a superior base and an inferior apex. Also, the sacrum connects to the hip bones on both sides, forming the sacroiliac joints. The anterior and posterior sacroiliac ligaments support this joint anteriorly and posteriorly. Next, there's the coccyx, also called the tailbone, which is a small triangular bone formed by the fusion of 4 vertebrae. Inferiorly, it attaches to the apex of the sacrum and forms the last part of the vertebral column. Ever wondered why it's called the tailbone? Well, that's because the coccyx is the remnant of a tail-like structure found in human embryos between weeks 4 and 8, called the caudal eminence. But it's not just an embryonic remnant. Multiple structures attach to the coccyx. These include parts of the gluteus maximus and coccygeus muscles, and a ligament called the anococcygeal ligament. Now, as the name suggests, the musculoligamentous part of the posterior wall is composed of muscles and ligaments. The piriformis is the main muscle which forms the posterolateral walls of the pelvic cavity. It originates from the superior part of the sacrum, goes through a foramen called the greater sciatic foramen, and finally attaches to the superior border of the greater trochanter of the femur. The ligaments that form the posterior wall are the anterior-sacroiliac, sacrotuberous, and sacrospinous ligaments. The anterior sacroiliac ligament is one of the ligaments that supports the sacroiliac joints anteriorly. The sacrotuberous ligament passes from the posterior surface of the ilium and the lateral surfaces of the sacrum and coccyx to the ischial tuberosity. Finally, the sacrospinous ligament passes from the lateral surface of the sacrum and the coccyx to the ischial spine. The pelvic floor, or pelvic diaphragm, is musculofascial, meaning that it is composed of a group of muscles and the fascia covering them, called the fascia of the pelvic floor. The pelvic floor separates the pelvic cavity superiorly from the perineum inferiorly, which is the space between the anus and the scrotum in males and between the anus and the vulva in females. The muscles that form the pelvic diaphragm are the coccygeus and the levator ani. The coccygeus are triangular muscles that run from the ischial spine to the lateral surfaces of the sacrum and coccyx. These muscles are innervated by branches of spinal nerves S4 and S5, and each coccygeus muscle flexes the coccyx anteriorly, helping it bear the body weight while sitting. Now, the levator ani muscle is the larger muscle forming the pelvic floor. Each levator ani originates anteriorly from the body of pubic bones and to the ischial spines posteriorly. Between these two bony origins, each levator ani muscle attaches to the tendinous arch of the levator ani, which is a medial thickening of the obturator fascia, called the tendinous arch of the levator ani. The pelvic diaphragm spans between the anterior, lateral, and posterior walls of the pelvis, closing most of the pelvic girdle ring, but it leaves a small gap anteriorly just behind the pubic bones called the urogenital hiatus. In females, the vagina passes through this gap, as well as the urethra in both females and males. The levator ani forms the dynamic floor that supports the abdominopelvic viscera. And most of the time, it's contracted to assist in maintaining urinary and fecal continence. So basically, it helps us hold it in until we can get to the bathroom, or a bush where no one's looking. It also contracts during forced expiration, sneezing, coughing, and vomiting to increase viscera support during times of increased intra-abdominal pressure. And finally, it relaxes in order to allow urination or defecation. Alright, now the levator ani muscle consists of 3 parts: puborectalis, pubococcygeal, and iliococcygeal. All 3 are innervated by the nerve to levator ani coming from branches of S4, the inferior anal nerve, and coccygeal plexus. The puborectalis is the thicker, narrower, medial part of the levator ani, and it bounds the urogenital hiatus from both sides. And its name kind of gives away the whole story. Pubo means that this part attaches to the posterior surfaces of the bodies of the pubic bones anteriorly, and rectalis means that this part forms a sling around the ano-rectal junction. Easy, right? The puborectalis is U-shaped, with the tips of the U attached anteriorly to the posterior surfaces of the bodies of both pubic bones. The bowl of the U forms a puborectal sling around the junction between the rectum and the anus, called the ano-rectal junction or flexure. So, when all is said and done, the puborectalis plays a major role in maintaining fecal continence. Next, there's the pubococcygeus, which is the wider, thinner, intermediate part of the levator ani muscle. This part arises lateral to the puborectalis, from the posterior surfaces of the bodies of pubic bones, in addition to the anterior tendinous arch. The lateral muscle fibers go posteriorly to attach to the coccyx, hence its name, pubococcygeus. The medial muscle fibers of the paired pubococcygeus muscles fuse in midline to form a median tendinous raphe, which forms part of the anococcygeal body, or ligament between the anus and coccyx, often referred to as the levator plate. This raphe unites with the external anal sphincter, forming a ligament that extends between the coccyx and the anus, called the anococcygeal body, or ligament. The main action of the pubococcygeus muscle is to maintain urinary continence and help in male ejaculation. Finally, there's the iliococcygeus, which is the posterolateral part of the levator ani. This part arises from the ischial spines and tendinous arch, and inserts on the coccyx and anococcygeal body. It is usually thin and poorly developed, and it usually looks like a fibrous tissue rather than muscle fibers. Alright, as a quick recap. The pelvic cavity is a funnel-shaped cavity bounded superiorly by the pelvic inlet, and inferiorly by the pelvic floor or diaphragm. It has an antero-inferior wall, 2 lateral walls, and a posterior wall. The antero-inferior wall is formed by the bodies and rami of pubic bones. The lateral wall is formed by the obturator membrane and the obturator internus muscle. Finally, the posterior wall is formed by the sacrum and coccyx, and the anterior sacroiliac, sacrotuberous, and sacrospinous ligaments. The pelvic floor contains 2 muscles, the coccygeus and the levator ani. Those muscles support the pelvic viscera and help in maintaining fecal and urinary continence.
The pelvic girdle, or the bony pelvis, is a bony ring formed by the left and right hip bones and the sacrum, and it surrounds the pelvic cavity and connects the vertebral column to the lower limbs. The main function of the pelvic girdle are to transfer the weight of the upper body to the lower limbs when sitting or standing and provide attachment points for muscles that help with locomotion and posture. It also provides support and protection for the abdominopelvic structures. So let's start with the hip bones. The right and left hip bones are irregular shaped bones located at the sides of the pelvic cavity, which bound and form the lateral walls of the pelvis. Each one of these hip bones developed from the fusion of 3 bones, the ilium, ischium, and pubis. Now let's start with the upper part of the hip bone, the ilium. You can think of the ilium as a fan. It has an upper expanded part representing the spread of the fan, called the ala, and a lower narrow part representing the handle of the fan, called the body. Now, there are 4 bumps coming off the ilium called spines. Let's talk about them. If we look anteriorly to the ilium, we can see two of the spines. One of them is superior and the other one is inferior. The naming is easy because it follows the rule of anterior or posterior plus superior or inferior. The superior one is called the anterior superior iliac spine, and the inferior one is called, you guessed it, the anterior inferior iliac spine. Now, looking at the ilium from a posterior view, we can see the remaining two spines, one superior and, again, one inferior. If we follow the rule just mentioned, we can name them easily. The superior one is called the posterior superior iliac spine, and the inferior one is called, wait for it, posterior inferior iliac spine. The main function of the spines is to provide attachment points for various muscles. For example, the longest muscle in the body is called the sartorius, and it attaches to the anterior superior iliac spine. Now, let's move to the next part of the ilium, the iliac crest, which is the rough, curved uppermost part of the ilium, representing the rim of the fan. The iliac crest runs between the anterior superior iliac spine and the posterior superior iliac spine. Now, when looking at the anteromedial surface of the ilium, we can see a fossa called the iliac fossa. This fossa is covered by a muscle called the iliacus. From a posteromedial view, we can see the auricular surface of the ilium. Right and left auricular surfaces of both ilia articulate with the sacrum, forming two sacroiliac joints. Above the auricular surface, there's an even rougher bit of bone called the iliac tuberosity, which has synovial and syndesmotic articulation with the reciprocal surface of the sacrum. Posteriorly, the ilium presents the gluteal surface. This surface is covered by three muscles called gluteus muscles. These muscles originate from lines on the gluteal surface of the ilium called posterior, anterior, and inferior gluteal lines. The gluteus minimus originates between the anterior and inferior gluteal lines. The gluteus medius originates between the anterior and posterior gluteal lines. And finally, the posterior gluteal line forms part of the origin of the gluteus maximus, which is the largest of the gluteal muscles. Moving on to the next part of the hip bone, the ischium. The ischium has two main parts, a body and a ramus. The body is the superior expanded part of the ischium that connects to the ilium superiorly and to the pubis anteriorly, and helps to form the acetabulum. The ramus is the lower, narrow part of the ischium that connects anteriorly to the lower part of the pubis, and helps form part of the obturator foramen. On the infero-posterior part of the ischium, there's a large, roughened area called the ischial tuberosity, which supports our weight while sitting, and where the inferior gemellus muscle and the hamstrings attach. At the junction of the body and ramus, there's a pointed projection called the ischial spine, where the sacrospinous ligament and superior gemellus muscle originate. Below the ischial spine, specifically between it and the ischial tuberosity, there's an arc called the lesser sciatic notch, and above the ischial spine is the greater sciatic notch, which is formed by parts of both the ischium and the ilium. Alright, now let's move on to the third and final part of the hip bone, the pubis. The pubis has three parts, a body, superior ramus, and inferior ramus. The body of the pubic bone is the thickest, most anterior part of the pubic bone. The superior ramus of the pubis connects to the ilium, forming the iliopubic ramus. The inferior pubic ramus connects to the inferior ramus of the ischium, forming the ischiopubic ramus. The angle at which both of these converge is called the pubic arch. Next is the pubic crest, which is a thickening on the anterior part of the pubis where the abdominal muscles attach. It has a swelling on its lateral side called the pubic tubercle, which is the distal attachment point of the inguinal ligament. The pectineal line, or pecten pubis,
is an oblique ridge located on the lateral part of the superior pubic ramus, and it's where the pectineus muscle originates from. Anteriorly, the bodies of the right and left pubic bones are joined together in the median plane through a fibrocartilage called the interpubic disc. This connection forms a joint called the pubic symphysis. The pubic symphysis is a secondary cartilaginous joint that is supported superiorly by the superior pubic ligament, which connects the pubic bodies to the interpubic disc, and inferiorly by the inferior pubic ligament, which forms the apex of the pubic arch. When the bodies of the two pubic bones meet, they form an angle inferiorly called the subpubic angle. The pubic symphysis is important in stabilizing the pelvic girdle and transferring weight from the upper body to the lower body, and it undergoes important changes during childbirth to allow the fetus to pass through the birth canal. Now, looking at the hip bone from a lateral view, we can see a deep cup-shaped fossa called the acetabulum. This fossa is formed by the body of the ilium, the body of the ischium, and the superior ramus of the pubis. The head of the femur fits into this fossa, forming the hip joint. And right below the acetabulum, there's the obturator foramen. The obturator foramen is bound by the ramus of the ischium and the inferior ramus of the pubis, and it's partially covered by the obturator membrane. The small part of the obturator foramen that's not covered by the membrane is called the obturator canal, through which the obturator nerve and obturator blood vessels pass to supply structures in the medial compartment of the thigh. Also, the obturator membrane gives origin to two muscles, called the obturator internus and externus muscles. Now let's take a quick break. Pause the video and see if you can recall some of the most important features of the ilium, ischium, and pubis. Alright, now let's switch gears and talk about the sacrum. The sacrum is a wedge-shaped bone composed of 5 fused sacral vertebrae. The sacrum forms the posterior-superior wall of the pelvic cavity, and it has a superior base and an inferior apex. The base of the sacrum is formed by the superior surface of the S1 vertebra. Now, in its uppermost portion, the S1 vertebra has an anterior lip called the sacral promontory, which arches a bit towards the front. And on both sides, the sacral vertebrae extend laterally to form the sacral ali. The apex of the sacrum, its tapering inferior end, articulates inferiorly with the coccyx, forming the sacrococcygeal joint. This joint is a secondary cartilaginous joint, and is supported by the anterior and posterior sacrococcygeal ligaments. Alright, now the sacroiliac joints connect the sacrum to the hip bones, and they actually consist of 2 joints. An anteriosynovial joint, which is formed by the articulation between the sacrum and the auricular surfaces of the ilium, and a posterior syndesmosis joint, formed by the articulation between the tuberosities found on the posterior surfaces of the ilium and the sacrum. The synovial portion is unlike other synovial joints as it has very limited mobility. But that's because their main role is to transmit the weight of the body into the hip bones. The sacroiliac joint is supported by multiple ligaments, including the anterior and posterior sacroiliac ligaments, which is synonymous with the fibrous synovial capsule, and they support the joint anteriorly and posteriorly. A third sacroiliac ligament, the interosseous sacroiliac ligament, is a primary structure involved in transferring weight, and lies between the sacral and iliac tuberosities in the anterior synovial joint. There's also the sacrotuberous ligament, which goes from the posterior surface of the ilium and the lateral surfaces of the sacrum and the coccyx to the ischial tuberosity. And that's why it's called the sacro, referring to the sacrum, and tuberous, referring to the ischial tuberosity ligament. See? A lot of these ligaments are named based on their origin and insertion points, making them easier to remember. A similar ligament, called the sacrospinous ligament, passes from the lateral surface of the sacrum and the coccyx to the ischial spine. These two ligaments convert the greater and lesser sciatic notches into the greater and lesser sciatic foramina, as shown here. There are multiple important structures passing through these two foramina. For example, the sciatic nerve passes through the greater sciatic foramen to enter the posterior thigh. This nerve and its branches supply structures in the back of the thigh and the leg. Finally, the iliolumbar ligament binds the fifth lumbar vertebrae to the iliac crest of the ilium. The sacrotuberous, sacrospinous, and iliolumbar ligaments are called the vertebropelvic ligaments because they bind parts of the vertebral column to the hip bones. All right, I know that was a lot. Take a deep breath. And let's move on to the pelvis itself. The pelvis has a superior opening called the pelvic inlet and an inferior opening called the pelvic outlet. Both the sacrum and the hip bones participate in forming these openings. The bony edge defining the pelvic inlet is called the pelvic brim. Posteriorly, there's a sacral promontory and the ala of the sacrum. Laterally, there's a linea terminalis, which is composed of the arcuate line of the ilium and pecten pubis. Anteriorly, the pelvic brim is formed by the pubic symphysis. On the other hand, the pelvic outlet is bounded by the tip of the coccyx posteriorly, the inferior margin of the sacrotuberous ligament posterolaterally, and ischial tuberosities laterally, and the pubic arch anteriorly. Now the pelvic inlet divides the pelvic cavity into an upper, larger area called the greater or false pelvis, and a smaller, lower area called the lesser or true pelvis. Each part of the pelvis has its own boundaries. Let's start with the greater or false pelvis. The greater pelvis is superior to the pelvic inlet and defined by the ala of the ilium posterolaterally, and by the first sacral vertebra posteriorly. It contains the ilium and the sigmoid colon. The lesser pelvis is between the pelvic inlet and outlet, and is bounded by the hip bones, sacrum, and coccyx, and contains organs of the urinary and genital systems. Now, in anatomical position, the pelvis is tilted in the anterior-posterior plane in a way that makes the right and left anterior-superior iliac spines in the same plane as the pubic symphysis. This anterior pelvic tilt makes the pubic bones appear to be located inferiorly instead of anteriorly, making the pubic bones and pubic symphysis the main weight-bearing contributors. This also means the pelvic inlet is more vertical than horizontal. Also, this orientation of the pelvis makes the superior surface of the sacrum visible when looking at the pelvis from an anterior view. Furthermore, the acetabulum faces inferior laterally and articulates with the head of the femur, and the obturator foramen is inferior medial to the acetabulum. Finally, there are differences between male and female pelvis. These differences are mainly due to the heavier build and larger muscles of men compared with the female pelvis, which is adapted for childbirth. The male pelvis is thick and heavy compared to the female pelvis, which is thin and light. The lesser or true pelvis is narrow and deep in males, but wide and shallow in females. Also, in males, the pelvic inlet is heart-shaped, while in females it's oval-shaped. The pelvic outlet is comparatively small in males, but large in females, to give the fetus enough room to come out of the pelvis. Finally, there are differences between the male and female pelvis, which is below 70 degrees in males, but is more than 80 degrees in females. But these differences are not solely the interest of obstetrics and gynecology specialists. Other medical specialties, such as forensic medicine, use these facts to determine the gender of skeletal remains. However, remember that even though there are some differences between the male and female pelvis, the pelvis of any person may have some features of the opposite sex. Alright, as a quick recap, the pelvic girdle is composed of 3 bones, the 2 hip bones and the sacrum, and it connects the vertebral column to the lower limbs. Each hip bone is composed of 3 parts, the ilium, ischium, and pubis. Also, the 2 hip bones are connected posteriorly to the sacrum and anteriorly to each other through the pubic symphysis. The sacrum is connected to the ilia through the sacroiliac joints. These joints are supported by the sacrospinous and sacrotuberous ligaments, which help form the boundaries of the greater and lesser sciatic foramina. The pelvic cavity has a superior entrance called the pelvic inlet, and an inferior exit called the pelvic outlet. The pelvic inlet splits the pelvis into the greater and lesser pelvis. Now, in an anatomical position, the pelvic girdle is tilted in a way that brings the anterior superior iliac spine and the pubic symphysis line in the same plane. Finally, the male and female pelvises are different because males have a larger muscle mass, so their pelvis is thicker and heavier, while the female pelvis is adapted to childbirth, so it has a more spacious lesser pelvis and a larger pelvic outlet.
The pelvis contains numerous structures, all supplied by the neurovascular structures of the pelvis, including nerves, arteries, veins, and lymph nodes. These structures are found on the posterolateral walls of the pelvic cavity. Lymph nodes are usually clustered around the veins, and lymph vessels that come off these nodes ascend parallel to the veins. Let's focus our attention on the arteries and veins of the pelvis. Now, the arteries of the pelvis originate from the abdominal aorta, which is the continuation of the thoracic aorta below the aortic hiatus in the diaphragm. The abdominal aorta gives branches to various organs in the abdomen, then divides at the level of the fourth lumbar vertebra into the right and left common iliac arteries. Each artery runs inferolaterally and ends at the level of the intervertebral disc between L5 and S1 by dividing into the internal and external iliac arteries. Let's talk about each of those branches. First are the external iliac arteries, which descend on the medial border of a muscle called the psoas major. After running for a short distance, each external iliac artery gives two branches, called the inferior epigastric and deep circumflex iliac arteries. These branches supply the anterolateral aspect of the abdominal wall. Then, each external iliac artery passes underneath the inguinal ligament to become the femoral artery, which is the main artery that supplies the lower limbs. Next are the internal iliac arteries, which are the main arteries of the pelvis and also supply parts of the gluteal region, medial thigh, and perineum. The branching pattern of the internal iliac arteries is one of the most variable in the body, so in order to identify each branch, we must think about the structures they're nourishing. Each internal iliac artery runs posteromedially to reach the upper border of the greater sciatic foramen. Then, each internal iliac artery divides into anterior and posterior divisions, or trunks. These trunks give smaller branches that are either visceral or parietal. Visceral branches supply organs, like the bladder and the rectum, and parietal branches supply muscles and skin that form the walls of the pelvic cavity. Let's zoom in on the branches of the anterior division of the internal iliac artery. There are 9 branches coming off the anterior division of the internal iliac artery: the umbilical, superior vesicle, inferior vesicle, obturator, uterine, middle rectal, internal pudendal, and the inferior gluteal arteries. And in biologically female individuals, there are also vaginal arteries. To make things a bit easier to remember, these branches are grouped into 3 categories, each with 3 branches. The first group includes the branches that supply the urinary organs, which are the umbilical, superior vesicle, and inferior vesicle arteries. The next group has 3 branches that supply the organs of the pelvis, which are the uterine, vaginal, and middle rectal arteries. Finally, 3 branches supply the walls of the pelvis, and these are the obturator, internal pudendal, and inferior gluteal arteries. Remember that these branches also supply structures of the genitourinary tracts, so they'll have variations depending on whether you're born biologically male or female. So let's start off with the umbilical arteries, which run antero-inferiorly along the lateral wall of the pelvis and ascend towards the umbilical ring. Before birth, the umbilical arteries are the main continuation of the internal iliac arteries and pass through the umbilical ring and travel through the umbilical cord to deliver nutrient and oxygen-poor blood from the fetus to the placenta. Here, the blood becomes replenished with nutrients and oxygen and is sent back to the fetus by the umbilical vein. After birth, the umbilical cord is cut and the umbilical arteries obliterate distally. The obliterated parts of the umbilical arteries persist as fibrous cords called the medial umbilical ligaments, and they're covered by folds of peritoneum called the medial umbilical folds. In an adult, these folds are seen on the inside of the anterior abdominal wall, and they sit lateral to the median umbilical fold, which contains the urachus, another fibrous remnant of an embryonic structure called the allantois. Finally, lateral to the medial umbilical folds, there are the lateral umbilical folds, which is peritoneum covering the inferior epigastric artery and vein. So, to quickly summarize, remember the single median umbilical fold sits on the median line of the body. The paired medial umbilical folds are on either side of the median umbilical fold. And finally, the lateral umbilical folds are most lateral. Okay, now each umbilical artery gives multiple superior vesical artery branches proximal to the medial umbilical folds in adults. The superior vesical arteries supply the superior aspect of the urinary bladder. In males, the superior vesical arteries may also give a branch to the ductus deferens or vas deferens, which facilitates the transport of sperm from the scrotum. There's also an inferior vesical artery that's only found in males, whereas in females it's replaced by the vaginal artery, which has inferior vesical branches. In males, the inferior vesical arteries supply the inferior aspect of the urinary bladder, the prostate gland, seminal glands, and pelvic parts of the ureters. Finally, the branch to the ductus deferens may arise from the inferior vesical arteries instead of arising from the superior vesical arteries. Next are the obturator arteries, which pass antero-inferiorly on the obturator fascia that covers the obturator foramen. Interestingly, in 20% of the population, an accessory or aberrant obturator artery arises from the inferior epigastric artery. Before leaving the pelvis, each obturator artery gives off multiple branches. First are muscular branches, which supply the muscles of the pelvis. Then it gives a nutrient artery that supplies part of the ileum. Finally, it gives a branch called the pubic branch, which ascends on the internal surface of the pubis. Each pubic branch anastomoses with the pubic branch of the opposite side. Finally, the obturator artery passes through the obturator canal to enter the lower limb and supply the medial compartment of the thigh. Next are the uterine arteries, which are the female counterpart to the artery of ductus deferens in males. These arteries most often arise from the anterior division of the internal iliac artery, but may arise from the umbilical artery. Now, the uterine arteries descend on the lateral walls of the pelvis, crossing superior to the ureters on each side, and then turn medially to reach the junction between the cervix and the vagina. You can think about the uterine arteries as a bridge over a river, where the bridge is the uterine artery and the river is the urine passing through the ureters to the urinary bladder. At the junction of the cervix and the vagina, each uterine artery divides into two branches, a small descending branch called the vaginal branch, which supplies parts of the vagina and the cervix, and a larger ascending branch, which runs superiorly along the lateral margins of the uterus, supplying it. Each ascending branch gives two branches, the ovarian branch, which supplies the medial aspect of the ovaries, and the tubal branch, which supplies the medial end of the uterine or fallopian tube. And now, an important point. Besides the vaginal branch of the uterine artery, in females there's also a vaginal artery per se. The vaginal artery gives two branches, the vaginal branch, which gives multiple branches for the anterior and posterior aspects of the vagina, and the inferior vesical branch, which nourishes the inferior aspect and the fundus of the urinary bladder. The vaginal artery anastomoses with the vaginal branch of the uterine artery, and the inferior vesical branches anastomose with the superior vesical branches of the umbilical artery. Next is the middle rectal artery, which can have a variable origin from the anterior division of the internal iliac artery and descends into the pelvis to supply the inferior parts of the rectum, the prostate, and seminal gland in males, as well as parts of the vagina in females. The middle rectal artery anastomoses with the superior and inferior rectal arteries to supply the whole rectum. There's also the internal pudendal artery, which descends and runs anterior to the piriformis muscle and the sacral plexus. Then it leaves the pelvis by going through the greater sciatic foramen inferior to the piriformis muscles. Finally, the internal pudendal artery loops around the ischial spine along with the internal pudendal vein and the pudendal nerve to enter the ischioanal fossa via the pudendal canal. Then it passes through the lesser sciatic foramen to supply structures in the perineum. Anteriorly and anterolaterally, the perineum is bounded by the symphysis pubis and the ischiopubic rami. Posteriorly, the perineum is bounded by the lower part of the sacrum and the coccyx. Finally, there's the inferior gluteal artery, which is the largest terminal branch of the anterior division of the internal iliac artery. However, it may also originate from the posterior division in some individuals. Remember when we said that there was a lot of variability in this area? Well, we hate to say we told you so. The inferior gluteal artery passes posteriorly, usually between the second and the third sacral spinal nerves, S2 to S3. Then it leaves the pelvis next to the internal pudendal artery, inferior to the piriformis muscle. The name of this artery gives a clue about the structures it supplies, namely the gluteus maximus, which is the largest muscle in the human body. This artery also supplies muscles of the pelvic diaphragm, quadratus femoris, and piriformis muscles. Finally, it supplies the sciatic nerve, which is the largest nerve in the human body. Okay, so let's switch gears and talk about branches of the posterior division of the internal iliac artery. These branches can be remembered with the mnemonic PILS G. P means that this mnemonic is used to remember branches off the posterior division. IL is for the iliolumbar artery, L is for the lateral sacral artery, and SG is for the superior gluteal artery. Let's start with the iliolumbar artery. Its course is a bit different from other arteries, meaning it runs in the opposite direction of its origin. Instead of running inferiorly, like the posterior division, it runs supralaterally, reaching the iliac fossa. In the fossa, the iliolumbar artery gives two branches, called the iliac and lumbar branches. The iliac branch supplies the ilium and the muscle covering the iliac fossa, called the iliacus, while the lumbar branch supplies the psoas major and quadratus lumborum muscles. Next are the superior and inferior lateral sacral arteries, which may arise independently from the posterior division or arise as a common trunk. The lateral sacral arteries pass both medially and descend anterior to the ventral rami of sacral nerves. These arteries give off the sacral branches, which pass through the anterior sacral foramina to supply the meninges surrounding the roots of sacral nerves. Also, some branches of lateral sacral arteries pass through the posterior sacral foramina to supply a group of back muscles called the erector spinae muscles. The last branch of the posterior division is the superior gluteal artery, which is the largest branch of the posterior division. This artery exits the pelvis through the greater sciatic foramen directly above the piriformis muscle. Then it enters the gluteal region to supply the gluteus maximus, medius, and minimus. So the gluteus maximus actually receives blood supply from both the inferior and superior gluteal arteries. Okay, now let's take a deep breath and have a quick quiz. This illustration shows branches of the anterior and posterior divisions of the internal iliac artery. So, do you recognize this artery? This is the iliolumbar artery, which is a branch of the posterior division. Pro tip, the iliolumbar artery is easy to find because it runs in the opposite direction of its origin. Okay, let's have another quick question. Can you name these arteries? Yep, these are the superior vesical arteries that arise from the anterior division. These are easy to find because they run to supply the superior surface of the urinary bladder. Last question, can you name this artery? Aha, it's the umbilical artery, which has an obliterated distal part running up to the umbilicus. Now, we also need to mention that there are some arteries that arise directly from the abdominal aorta and make their way down to the pelvis. These arteries are the gonadal arteries, median sacral artery, and superior rectal artery. The gonadal arteries supply the gonads, which are the testes in males and the ovaries in females. The course of gonadal arteries is similar between males and females, but the names are different. In males, they're called the testicular arteries, and in females, they're called the ovarian arteries. The gonadal arteries arise laterally from the abdominal aorta between the renal artery above and the inferior mesenteric arteries below. The gonadal arteries then descend towards the pelvis, where they travel behind the peritoneum and anterior to the ureters, to which they also supply branches. Our bridge over a river memory trick applies here as well. Then they enter the lesser pelvis and run medially to cross the origin of external iliac vessels. Now, the distal extension of the gonadal arteries differs between males and females. In males, the testicular artery runs through the inguinal canal and enters the scrotum to supply the testis and the epididymis. In females, each ovarian artery gives two branches. These are the ovarian branch, which supplies the ovaries, and the tubal branch, which supplies the fallopian tube. Next is the median sacral artery. This small single artery arises from the anterior or posterior surfaces of the abdominal aorta just above its bifurcation. After originating, the median sacral artery runs inferiorly along the anterior surface of the lower two lumbar vertebrae, the sacrum and the coccyx. As it travels distally, the median sacral artery gives off parietal and visceral branches. The parietal branches are called lateral sacral branches, which run laterally to anastomose with the superior and inferior lateral sacral arteries. Finally, the visceral branches run to the posterior surface of the rectum. There, these branches anastomose with the superior and middle rectal arteries and help provide minor blood supply to the rectum. Finally, there's the superior rectal artery, which is the direct continuation of the inferior mesenteric artery, a branch of the abdominal aorta which supplies the large intestine. Now, the superior rectal artery descends inferiorly to cross the left common iliac vessels. Then, it runs on the sigmoid colon to enter the lesser pelvis to supply each side of the rectum as far down as the internal anal sphincter. Now that we have gone through all of the arteries of the pelvis, let's review these arteries by focusing on the blood supply of major pelvic organs, starting with the bladder. The bladder is supplied by the superior and inferior vesical arteries. The superior vesical artery arises from the umbilical artery and supplies the superior aspect of the bladder. Next, the inferior bladder is supplied by the inferior vesical artery in males and the inferior vesical branches in females, which originate from the vaginal artery. Next is the blood supply of the female internal reproductive organs, which are the ovaries, fallopian tubes, uterus, and vagina. Now, the ovaries are mainly supplied by the ovarian arteries, which arise as direct branches from the abdominal aorta. The ovarian branches of the uterine artery also supply the medial aspect of the ovaries. Next are the fallopian tubes. These tubes are supplied by tubal branches that arise from uterine and ovarian arteries. Then comes the uterus, which is mainly supplied by the uterine artery, which arises as a direct branch from the anterior division of the internal iliac artery. Finally, the vagina is mainly supplied by the vaginal artery, which typically arises as a branch from the uterine artery. Additionally, small branches from the descending branch of the uterine artery provide blood to the vagina. Next is the blood supply of male reproductive organs, which are the testis, the prostate, and the ductus deferens. Now, the testes are supplied by the testicular artery, which arises as a direct branch from the abdominal aorta. The prostate is supplied by branches from the middle rectal and inferior vesical arteries, which arise as direct branches from the anterior division of the internal iliac artery. Finally, the ductus deferens is supplied by the artery to the ductus deferens, so no surprises there. This artery mainly arises from the superior vesical artery and sometimes from the inferior vesical artery. Finally, let's look at the blood supply to the rectum and the anal canal, which form the terminal parts of the gastrointestinal tract. The rectum is supplied by three main arteries called the superior, middle, and inferior rectal arteries. The superior rectal artery is the continuation of the inferior mesenteric artery, a direct branch of the abdominal aorta. The middle rectal artery arises from the anterior division of the internal iliac artery. Finally, the inferior rectal artery arises from the internal pudendal artery. The three rectal arteries may all anastomose with each other. Next, there's the anal canal, which is divided into an upper 2/3 and a lower 1/3 by a line called the pectinate or dentate line. The part of the anal canal that's above the dentate line is mainly supplied by the superior rectal artery, and the part below the dentate line is mainly supplied by the inferior rectal artery. Also, branches from the middle rectal artery supplies both parts of the anal canal. Now let's switch gears and talk about the pelvic veins. The major veins of the pelvis are the internal iliac veins. These veins form superior to the greater sciatic foramen and pass postero-inferior to the internal iliac arteries. Generally, the names of the venous tributaries that drain into the internal iliac veins are similar to the names of the branches that come off the internal iliac artery. However, they are more variable. Additionally, these tributaries drain the same areas that the arteries supply. Exceptions include the umbilical arteries, which don't have accompanying umbilical veins, as well as the iliolumbar veins, which originate in the iliac fossa and drain into the common iliac veins instead of the internal iliac veins. It's particularly important to understand the drainage of the testicular veins in males and ovarian veins in females. As the testicular and ovarian arteries are branches of the abdominal aorta, you would expect these veins to drain to its counterpart, the IVC. However, the right and left gonadal veins drain into different vessels. The right gonadal vein drains directly into the inferior vena cava, just below the right renal vein. On the other hand, the left gonadal vein drains into the left renal vein, which then drains into the inferior vena cava. Finally, the internal iliac veins unite with the external iliac veins to form the common iliac veins. Then, the right and left common iliac veins unite at the level of L4 or L5 to form the inferior vena cava, which runs upwards to drain into the right atrium of the heart. In addition to the tributaries of the internal iliac vein, there are multiple pelvic veins which are organized into interjoining networks called pelvic venous plexuses. These plexuses are named according to the name of the organ they surround. For example, venous plexuses surrounding the rectum are called rectal venous plexuses. Other venous plexuses include vesical, prostatic, uterine, and vaginal venous plexuses. Now, these venous plexuses mainly drain into the tributaries of the internal iliac veins. However, some drain into the superior rectal vein, which goes on to drain into the inferior mesenteric vein and onto the hepatic portal system. Now, because the superior rectal vein drains into the hepatic portal system, it creates what is called a portal caval anastomosis in the pelvis at its anastomosis point with the middle and inferior rectal veins, which both drain into the systemic venous system or caval system. This is clinically relevant when there's increased pressure in the portal hepatic system, leading to congestion and varices at these anastomosis points. Furthermore, some of the venous plexuses will drain into the lateral sacral veins, which drain into another plexus found in the spinal canal called the internal vertebral plexus. This connection between the lateral sacral veins and the internal vertebral plexus allows potential metastasis of prostatic or ovarian cancers to vertebral or cranial sites. Finally, a minority of the pelvic venous plexuses drain into the median sacral and ovarian veins. Alright, as a quick recap. Pelvic arteries supply oxygenated blood to the structures of the pelvis. The main artery that supplies structures of the pelvis is called the internal iliac artery, which bifurcates into an anterior division and a posterior division. Now, to make things a bit easier, branches off the anterior division are grouped into three categories. The first group has three branches that supply the urinary organs, which are the umbilical, superior vesical, and inferior vesical arteries. The next group has three branches that supply organs of the pelvis, which are the uterine, vaginal, and middle rectal arteries. Finally, three branches supply the walls of the pelvis, which are the obturator, internal pudendal, and inferior gluteal arteries. Next are branches off the posterior division, which can be remembered with the mnemonic PILS G. P means that this mnemonic is used to remember the branches off the posterior division. IL is for the iliolumbar artery. L is for the lateral sacral artery, and SG is for the superior gluteal artery. Finally, 3 branches come off the aorta and go down to supply structures in the pelvis. These are the gonadal arteries, median sacral artery, and superior rectal artery. Finally, pelvic venous plexuses lie on the surfaces of pelvic organs. These plexuses intercommunicate with each other and with superior veins and form clinically important connections such as the portacaval anastomosis of the rectal veins and the open communications between the lateral sacral veins and internal vertebral plexus.
The neurovascular structures of the pelvis include nerves, arteries, veins, and lymph nodes. These structures lie on the posterolateral walls of the pelvic cavity. Generally, the somatic nerves are the most lateral. Arteries lie medial to the nerves, and veins lie between these two. Lymph nodes are usually clustered around the veins, and lymph vessels that come off of these nodes ascend parallel to the veins. Now, let's take a closer look at the lymphatics and nerves of the pelvis specifically. Let's talk about the lymphatic drainage of the pelvis, which follows various major and minor groups of lymph nodes. These lymph nodes have variable sizes, numbers, and locations, and the lymph node clusters' names are based on the adjacent structures and nearby blood supply. Furthermore, these nodes are all interconnected, so their drainage often overlaps and can vary quite a bit. First, there are the inguinal lymph nodes, which lie around the inguinal ligament, and they're divided into superficial and deep inguinal lymph nodes. The superficial inguinal lymph nodes receive lymphatic drainage from the superficial lower limb, abdominal wall inferior to the umbilicus, gluteal region, and superficial perineal structures such as the distal vagina, vulva, and scrotum, and typically drain into the external iliac lymph nodes. The deep inguinal lymph nodes receive lymph from the superficial inguinal nodes, as well as the deep portions of the lower limb, the glans clitoris in females, or glans penis in males, and the distal spongy urethra. These nodes typically drain into the external and common iliac lymph nodes. Now, in addition to the inguinal lymph nodes, the external iliac lymph nodes also receive lymph from the anterior superior pelvic viscera, such as the body of the uterus, anterior cervix, and superior bladder. Finally, the external iliac lymph nodes drain lymph into the common iliac lymph nodes, which lie around the common iliac artery. Next are the internal iliac lymph nodes, which lie along the anterior and posterior divisions of the internal iliac artery. They drain lymph from inferior pelvic viscera and deep perineal structures, such as the prostate, cervix, and proximal vagina. Then, the internal iliac lymph nodes drain into the common iliac lymph nodes, just like the external iliac lymph nodes. Next are the sacral lymph nodes, which lie in the concavity of the sacrum near the median sacral blood vessels. These lymph nodes receive lymph from the more posterior and inferior pelvic structures, such as the inferior rectum and vagina. Then, they drain into the internal iliac lymph nodes or the common iliac lymph nodes. Finally, there are the common iliac lymph nodes, which lie along the common iliac blood vessels. These lymph nodes receive lymph from the external iliac, internal iliac, and sacral lymph nodes. Part of some pelvic viscera, like the neck of the urinary bladder and the inferior part of the vagina, may bypass other sets of nodes and drain their lymph directly into the common iliac lymph nodes. From the common iliac lymph nodes, lymph goes to the lumbar lymph nodes, which are also called caval or aortic lymph nodes. The aortic lymph nodes also drain lymph directly from the testes and ovaries and the fundus of the uterus. Before wrapping up the pelvic lymph nodes, it's worth mentioning a minor group of lymph nodes called pararectal lymph nodes. These lymph nodes lie in the connective tissue that surrounds branches of the internal iliac blood vessels. Alright, before we look at pelvic nerves, Feel free to pause the video and see if you can name the main lymph node groups of the pelvis. Okay, now let's switch gears and look at the nerves of the pelvis, which can be divided into somatic and autonomic nerves. Somatic nerves arise from the lumbosacral and coccygeal plexus. They include the obturator nerve, the lumbosacral trunk, and spinal nerves that arise from the sacral and coccygeal segments of the spinal cord. Sacral and coccygeal spinal nerves interconnect to form an extensive network of nerves called the sacral and coccygeal nerve plexuses, which lie on the piriformis and coccygeus muscles. Let's start with the obturator nerve, which arises from the lumbar plexus, specifically the anterior rami of the second, third, and fourth lumbar spinal nerves. This nerve enters the lesser pelvis and runs along the lateral wall of the pelvis to the obturator canal, which is an opening within the obturator membrane. After entering the obturator canal, the obturator nerve divides into anterior and posterior branches, which actually don't supply any structures within the pelvis. Instead, these branches enter the thigh and supply the adductor muscles of the medial thigh. Now, right above the pelvic brim, the descending part of the fourth lumbar nerve unites with the anterior ramus of the fifth lumbar nerve, forming the lumbosacral trunk. This trunk descends on the anterior surface of the ala of the sacrum, and it unites with the sacral plexus, forming the lumbosacral plexus. So the lumbosacral plexus is formed by the anterior rami of spinal nerves L4 through S4. This plexus lies on the posterior lateral wall of the lesser pelvis, and it gives off a number of branches for pelvic and lower limb structures. The first of these branches is the sciatic nerve, which is the largest nerve of the human body. This nerve arises from the anterior rami of spinal nerves L4 to S3. Then, it passes through the greater sciatic foramen, typically below the piriformis muscle, and enters the gluteal region. Finally, it descends on the posterior aspect of the thigh and gives branches that supply the hip joint, posterior muscles of the thigh, and all the muscles of the leg and foot. Second, there's the pudendal nerve, which arises from spinal nerves S2, S3, and S4. After it forms, the pudendal nerve leaves the pelvis through the greater sciatic foramen, between the piriformis and coccygeus muscles. Then, it winds around the ischial spine and the sacrospinous ligament. Finally, it passes through the lesser sciatic foramen and enters the perineum to provide sensory information to the external genitalia, as well as muscular branches to perineal muscles. Two other branches of the lumbosacral plexus are the superior gluteal and inferior gluteal nerves. The superior gluteal nerve arises from L4, L5, and S1. This nerve leaves the pelvis above the piriformis muscle, and it passes through the greater sciatic foramen to supply the gluteus medius and gluteus minimus muscles in the gluteal region. Finally, the inferior gluteal nerve, which arises from L5, S1, and S2. This nerve also leaves the pelvis through the greater sciatic foramen, but below the piriformis muscle. The inferior gluteal nerve supplies the gluteus maximus, which is the largest muscle of the gluteal region and, in fact, the entire body. Here's a memory trick. The relations of these nerves to the piriformis muscle correspond to their names. The superior gluteal nerve passes above the piriformis, and the inferior gluteal nerve passes below the piriformis. Okay, next the lumbosacral plexus gives off 5 nerves that are easy to memorize, because their name is the name of the muscle they innervate. First, there's the nerve to quadratus femoris, which arises from L4, L5, and S1, and supplies the quadratus femoris and inferior gemellus muscles. Second, there's a nerve to obturator internus, which arises from L5, S1, and S2, and supplies the obturator internus and superior gemellus muscles. Third, there's a nerve to piriformis, which arises from S1 and S2 and supplies the piriformis muscle. And the last two of these easy-to-remember branches are the nerves to the levator ani and coccygeus, which arise from S3 and S4 and supply the levator ani and coccygeus muscles. Finally, the sacral plexus gives off the posterior cutaneous nerve of the thigh and perforating cutaneous branches. And we're saying just the sacral plexus here, because only sacral nerves S1 through S4 contribute to these branches. So, the posterior cutaneous nerve of the thigh arises from S1 to S3 and supplies cutaneous branches to the buttocks and uppermost medial and posterior sides of the thigh. The perforating cutaneous branches, on the other hand, arise from S3 and S4 to supply the skin covering the medial side of the buttocks. Okay, now we're just going to quickly go over the other 24 branches of the sacral. Just kidding. Instead, you can take a quick break and see if you can recognize the sciatic, pudendal, and superior and inferior gluteal nerves on this image. And now, just a few words about the coccygeal plexus, which lies on the pelvic surface of the coccygeus muscle. This plexus is formed by the anterior rami of S4, S5, and the coccygeal spinal nerves. Branches of this plexus supply the coccygeus and levator ani muscles and the sacrococcygeal joint. This plexus also gives the anococcygeal nerve, which pierces the anococcygeal ligament to supply a small area of skin between the tip of the coccyx and the anus. And finally, let's look at the autonomic nerves of the pelvis, which includes sympathetic and parasympathetic nerves. Let's start off with the sympathetic nerves that reach the pelvic cavity through the sacrosympathetic trunks, periarterial plexuses, and hypogastric plexuses. First, there are the sacral sympathetic trunks, which continue the lumbar sympathetic trunks inferiorly and typically consist of 4 sympathetic ganglia. These trunks descend on the pelvic surface of the sacrum, medial to the sacral foramina. Along its course, each sacral trunk sends gray rami communicantes to each of the interior rami of the sacral and coccygeal spinal nerves. These trunks also send small branches that supply the inferior hypogastric plexus and the median sacral artery. The main function of these branches is to provide sympathetic innervation to the lower limb. Finally, the distal portion of these trunks converge anterior to the coccyx to form a small ganglion called the median ganglion impar, or the coccygeal ganglion. Next are the periarterial plexuses, which provide sympathetic fibers for the ovarian, superior rectal, and internal iliac arteries and their branches. These sympathetic fibers cause vasoconstriction, which means they make blood vessels narrow. Then there are the superior and inferior hypogastric plexuses, which provide autonomic innervation to the pelvic cavity and receive afferent impulses from the pelvic viscera. Now, the main part of the superior hypogastric plexus actually continues from another plexus called the intermesenteric plexus. The superior hypogastric plexus receives sympathetic fibers from the intermesenteric plexus by L3 and L4 splanchnic nerves. The superior hypogastric plexus lies inferior to the bifurcation of the aorta, descends and enters the pelvis, and then it divides into the right and left hypogastric nerves, which run along the anterior surface of the sacrum and eventually end up lateral to the rectum. Finally, the right and left hypogastric nerves merge with the pelvic splanchnic nerves and spread in a fan-like fashion to form the right and left inferior hypogastric plexuses, which contain sympathetic, parasympathetic, and visceral afferent fibers to innervate the pelvic viscera. Finally, there are the parasympathetic nerves called the pelvic splanchnic nerves, which arise from the anterior rami of spinal nerves S2 through S4. These nerves carry preganglionic parasympathetic fibers from spinal cord segments S2 through S4 to the inferior hypogastric plexuses, which carry these fibers to various pelvic viscera. Also, the pelvic splanchnic nerves carry visceral afferent fibers from pelvic viscera to the sensory spinal ganglia of spinal nerves S2 through S4. Now, each part of the autonomic nervous system serves a bunch of roles in the pelvis. The sympathetic innervation of the hypogastric and pelvic plexuses inhibits peristaltic contraction of the rectum, and it also stimulates the contraction of internal genital organs during orgasm, which results in ejaculation. The parasympathetic system, on the other hand, stimulates the contraction of the rectum for defecation, and that of the bladder for urination. Also, there are a group of parasympathetic fibers and a plexus found on the surface of the prostate gland, called the prostatic plexus. These fibers penetrate the pelvic floor and innervate the external genitalia, which causes erection. Finally, there are the afferent visceral fibers, which receive sensory impulses from the pelvic viscera and typically travel with the parasympathetic fibers via the inferior hypogastric plexus and pelvic splanchnic nerves of S2 through S4. However, the course and the destination of these sensory fibers differ, and this depends on whether these fibers are sensing superior or inferior to an imaginary line called the pelvic pain line. This line corresponds to the inferior limit of the peritoneum that extends into the pelvic cavity, and pelvic organs can be either superior or inferior to this line. Superior organs include the abdominopelvic organs that lie within the peritoneum or are in contact with the peritoneum, like the kidneys, the ureters, superior parts of the bladder, and the upper part of the uterus. Inferior organs include the organs that lie inferior to the peritoneum, like the rectum, cervix, and vagina. Of note, the pelvic pain line does not correlate with the peritoneum in the large intestine, and it goes through the middle of the sigmoid colon. So, pain sensation that comes from superior organs follows along the sympathetic nerves in a retrograde fashion, traveling up the hypogastric and aortic plexuses. Then they are carried by the abdominopelvic splanchnic nerves to the lumbar sympathetic trunks and white rami communicantes. Finally, they reach the cell bodies in the inferior thoracic and upper lumbar spinal ganglia. Pain sensation that comes from the inferior organs also travels in a retrograde fashion, but this time along parasympathetic nerves. These sensations pass through the pelvic and inferior hypogastric plexuses to reach the cell bodies of the spinal sensory ganglia of S2 through S4. Alright, as a quick recap, lymphatic drainage of the pelvis includes major and minor lymph nodes. Major groups of lymph nodes include the superficial and deep inguinal, internal iliac, external iliac, sacral, and common iliac lymph nodes. The nerves of the pelvis can be divided into somatic and autonomic nerves. Somatic nerves arise from the lumbosacral and coccygeal plexus, and they are the obturator, sciatic, superior gluteal, inferior gluteal, and pudendal nerves, the nerve to piriformis, nerve to quadratus femoris, nerve to obturator internus, and nerves to levator ani and coccygeus, and finally the posterior cutaneous nerve of the thigh. Autonomic nerves of the pelvis include the sacral sympathetic trunks, which supply the lower limb, the periarterial plexuses, which supply motor fibers to the superior rectal, ovarian, and internal iliac arteries and their branches, the hypogastric plexuses, which are the main origin of sympathetic fibers in the pelvis, and pelvic splanchnic nerves, which are the main origin of parasympathetic fibers in the pelvis. There are also visceral afferent fibers, which receive sensory information from the pelvic viscera. Above the pelvic pain line, these fibers travel with sympathetic fibers, and below the pelvic pain line, they travel with the parasympathetic fibers.